So we have two interesting cases today. We'll start with the first one. The clinical information, I think Dr. Jefferson will present the clinical information, right?
Yes, I'm here.
Okay, cool.
So this man presented to adult nephrology when he was 23 and was admitted to the UW Montlake with nephrotic syndrome and acute kidney injury. But his medical history starts very young. At the age of 18 months, he had some form of enteritis and was initially diagnosed with Crohn's disease. At the age of 4, he developed a second autoimmune disease and was diagnosed with insulin-dependent diabetes. And then at age 7, possibly a third autoimmune disease, juvenile arthritis, possibly juvenile rheumatoid arthritis. And for many years, he's been treated with infliximab and methotrexate, insulin, obviously. And things are reasonably well controlled in that for many years. And then at the age of 13, he presented with nephrotic syndrome. Now, I don't have all the clinical details. Are you going to show that biopsy?
Yes.
Okay, well, I guess I can tell you now that at that time, he presented with membranous nephropathy. This was, do you want to discuss further, or do you want to show that biopsy?
Okay, I'll show that biopsy first. So this is the first biopsy from 2011. And he has 3 biopsies in total, one in 2011, one in 2014, and the most recent in 2023. So this is the first biopsy. So this is the renal parenchyma we got, which was done in Children's Hospital. We have 3 cores of renal cortex and a lot of glum, about 69 to 83 glomeruli per level section, and 2 to 4 glomeruli are sclerosed per level section. The chronic parenchyma injury, as you can see here from the low power view, it's pretty minimal, about 5%. It's patchy and mild. And this is a kind of zooming picture of the renal parenchyma. As you can see here, it's pretty well preserved. And the glomeruli here, they may have some subtle changes, but what I can tell is that there is no any kind of active lesions. For example, the crescent formation or segmental necrosis, so none of these. If we take a closer look of the glomeruli, what we can see is that there is some mottled appearance of the basement membrane. That's probably the most thing you can tell. But even these kind of changes, it's very subtle. So trichrome staining actually could be more helpful in this case. So the green arrow is pointing to some of the eosinophilic, maybe located in the subepithelial area for these deposits. The possible deposits at the subepithelial location. And now IF shows 3+ diffuse granular capillary wall staining for IgG and C3. There's also 1+ C4 staining along the capillary wall. So what EM shows is that there is those scattered subepithelial deposits. It's not really associated with the basement membrane reaction here. And the overlying podocytes is showing pretty extensive process effacement. So again, another image showing you the subepithelial deposits, electron-dense deposits. So the diagnosis at that time was membranous nephropathy. So PLA2R was done at that time, but it was not shown on the pathology report. So I'm not exactly certain if it was done. Okay, let me go back to here.
So presented with membranous at the age of 13. I saw in the notes that it was reported as PLA2R and THSD7A negative, but
Okay,
maybe we don't
that's
have that.
good to know. Yeah.
And it wasn't clear to me whether this was antibody testing or tissue staining at that time. Either way, the patient was treated. I'm not exactly sure if the treatment at that stage had certainly included cyclosporin, but following this, he achieved complete remission, and then was actually continued on the cyclosporin long term. So was on infliximab, methotrexate, and cyclosporin long term after this. Age 14, developed this condition I'm not really familiar with, chronic recurrent multifocal osteomyelitis. This is a non-infectious form of kind of inflammatory disease, like an enthesiopathy. And there's also a history of uveitis at one stage, and what was variably described as psoriasis or dermatitis or possibly eczema, but he had a skin disease at one stage as well. So obviously multiple autoimmune diseases, 5 or 6 of them, and it was at the age of 20 when he actually had a genetic diagnosis, and he was found to have this condition called IPEX syndrome. So IPEX stands for immune dysregulation, polyendocrinopathy, enteritis, and the X is it's X-linked, so boys more severely affected than girls. Typically presents very early, and often diarrhea is the first presentation, as with this patient. And this is a very interesting disease. It's due to mutations in FOXP3. You want to talk more about this?
Yeah,
Okay.
I think, yes. Sorry for going.
Maybe we can discuss the IPEX right at the end.
Okay.
Let's continue with the actual case. It might be helpful.
Okay, that sounds good.
Yeah, so the one-liners, FOXP3 is important. It encodes a transcription factor in the development of Treg cells. So you get impaired T regulatory function, and this leads to kind of an excess T cell and B cell upregulation.
Yeah, I would just add actually that, yeah, so Tregs, we think of them, as kind of suppressing immune responses. And so in a way, the absence of these cells, because of the absence of this transcription factor, allows immune responses and autoimmune responses to go unchecked. And this explains why these patients can develop multiple autoimmune diseases targeting multiple organs at a very early age as well.
Okay, so now to the adult presentation. So he was actually, despite all these diseases, he was actually relatively well controlled. He's employed. He's well, I can't remember what height he is, but he's a fairly big guy. He might be 5'10", 6 foot. So he actually looks quite well. So he in November 2022 he had a wisdom tooth removed. This was followed, I suppose, understandably by facial swelling. Unfortunately, the facial swelling got worse. He developed peripheral edema and an 11-kilogram weight gain. And then 10 days after the wisdom tooth was removed, he was admitted to Montlake with acute kidney injury. His creatinine was 3.6. He had 6.6 grams per gram of proteinuria. Later on, we found that he had discontinued his cyclosporin some months beforehand, some months, possibly years. It's a little unclear. On examination, he was hypertensive when he came in, 154/77, but was saturating 100% on room air. He had clinical features of nephrotic syndrome. His chest was clear. He had no rash at this stage. And the rest of his exam was essentially within normal limits. So these are his investigations on admission. His urine showed 3+ blood, 3+ protein, quantified at 6.6 grams per gram, and was markedly hypoalbuminemic with a serum albumin of 2.5. Urine sediment revealed some fine granular casts. There was a few red blood cells, and there was a question of whether there were dysmorphic blood cells there, but not convincing. Blood testing showed slight anemia. Hematocrit was 33%. His white cell count was 10.6. Immunological workup, his complement levels were normal. ANA was negative. Antiphospholipid antibody was negative. but notably he was ANCA positive. So his ANCA was, the titer was, or the dilution was 1 to 8, but his anti-PR3 antibody was very high on ELISA at 50. Virology was negative, paraprotein workup was negative, and blood cultures were checked with the positive PR3, which were also negative, and a diagnostic biopsy was performed.
Okay, we already look at this one. I'm gonna skip this biopsy. And so before we go to the 2023 biopsy, I want to show you briefly the follow-up biopsy after the membranous treatment. So this was a case done in 2014. And so this is a core of renal biopsy, cortex humaning, 2 cores for that biopsy, and there are about 13 to 18 glomeruli per level section. Only 1 glomerulus per level section is globally sclerosis, no significant chronic parenchymal injury again. This is a closer look of the renal parenchyma. As you can see here, there's not much IFTA going on, and the glom look pretty unremarkable, at least at this low power examination. And this vessel here looks okay too. And for IF, so IgG was negative compared to the previous positive staining along the peripheral capillary wall. It's now negative. 1 glomerulus showed 2+ segmental finding granular staining along for IgA and IgM, but basically IgG for membranous nephropathy is negative. And for EM, the glomeruli, they show largely intact food processes. The food process effacement is patchy, it's only 10 to 20%. So this is the EM image for that biopsy. The food processes here is kind of majority of them is preserved. There's maybe segmental. It's not effacement here, but it's not really extensive. And then you can see those electron lucencies within the basement membrane and some densities as well, but you don't really see those subepithelial deposits anymore. So the diagnosis at that time was membranous nephropathy in remission. Now, the current, just to remind you, the current presentation, the patient had acute new onset nephrotic syndrome with AKI. Hemoglobin A1C before the biopsy was 9.3%. The question was if there is recurrence of membranous nephropathy, it was treated, it was in remission, and if there now he has this new onset of acute nephrotic syndrome. So this is one thing on the differential. Another is FSGS. So with these questions in mind, this is what we see on the renal biopsy. So we have 2 cores of renal cortex with
Sorry,
about.
Luan, do you want to
Yes.
just pause to see if there are any questions from the audience at this stage with regard to the
Yes.
biopsy or anything?
Yeah.
Hey, Ashley, was the patient still on infliximab at that time?
They were still taking infliximab, yes.
And it seems that on the first biopsy for membranous, it was positive for C4. So was the IgG subtraction done? I mean, it seems more likely classical pathway activation in secondary membranous as opposed to primary with IgG4.
I don't think IgG subtyping was done at that time. Yeah, that's a good question, but it was not done.
You can see IgG4 in primary membranous, especially early on. So it's not an absolute distinction.
Yeah, I agree with what Kelly was saying, and remember that this was, you know, in the early 2010s, pretty much very shortly after the discovery of PLA2R and reporting of PLA2R. So many of the tests that we now take for granted were not widely available at that time as well.
Mm-hmm. Any other questions? No, okay, I'm gonna continue with, so we have 2 cores of renal cortex with about 12 to 15 glomeruli per level section. And 2 to 4 glomeruli are sclerosed per level section. There is patchy, mild tuber atrophy and interstitial fibrosis here and there, but overall it's still mild. And if we take a closer look at the glum, what we can see is the mesangium here is slightly expanded by the matrix, and some area is a little bit hypercellular. So there is accumulation of matrix material and cells within the mesangium. But overall, the changes is subtle, and I don't really see like thickening of the glomerular basement membrane, at least based on this glomerulus here. In addition, what we see from the vessels is that there is some arterial hyalinosis, moderate arterial hyalinosis, and rarely there is adventitial hyaline nodules involving the arterioles. In the tuber interstitium, there is some mononuclear cell infiltrate, and occasionally you could see these lymphocytes with this nice halo surrounding it, infiltrating within the epithelium beyond the basement membrane. So there is rare tubulitis associated with the mononuclear cell infiltrate in the interstitium. So for IF, what we see is that the left panel on the is IgG staining and the right is the albumin staining. So for IgG staining, what you can see is that there is those dusting punctate staining over the podocyte cell body. It's pretty discernible and readable here. But if you compare to the albumin negative control, you don't see this similar finding, the punctate dusting staining along the podocyte cell body. And what you can see is as internal control in the proximal tubules, you can see those reabsorption, protein reabsorption droplets as an internal control.
So I would just add, actually, Johan, if you mind, come back, that, you might have read about this, and I'm sure Johan will discuss this further. But this dusting is pretty faint, and so we usually have to kind of bump up the gain and exposure to visualize it. And so as a control, we will take pictures of glomeruli for albumin at the same exposure settings to verify that we are seeing the dusting and it's not just something non-specific. So the space where the podocytes would be in the albumin image on the right is black, but you can see the kind of the granular fine speckling dusting pattern on the left side over the podocyte cell bodies.
Yes, yeah, exactly. Thank you. And those two images, they are taken at the same exposure. So this is a EM representative imagery. What we can see is that for the podocyte for processes, it's diffusely, it's extensively effaced. Also, sometimes you can see this microvillus transformation. Otherwise, the glomerular basement membrane, they are pretty unremarkable. You don't really see those electron lucency or densities anywhere, and maybe one occasional here. And also the subepithelial electron density deposits are not present by electron microscopy. So the diagnosis for the biopsy from 2023 was minimal change disease. Also, there is morphologically early diabetic nephropathy. There is acute tuber injury and focally active tuber interstitial nephritis. The chronic parenchymal injury is still pretty patchy and mild. And then the arterial hyalinosis, as I shown earlier, there is moderate arterial hyalinosis, a little bit arterial sclerosis as well. So recently, as we mentioned, for minimal change disease, there is, in a subset of minimal change disease, there are reports about the presence of autoantibodies targeting nephrin And what they found is that in these subset of minimal change disease, so this is the routine diagnostic immunofluorescence study done for IgG on the left and then albumin on the right. So similarly to what we see in our biopsy, they are the first group who identified those dusting pattern of staining along the podocyte cell body. And then on the right, albumin is served as the negative control here, and you don't see these punctate dusting, finding granular staining over the podocyte body. And if they do the IgG subtyping for these subset of minimal change disease, there are similar staining pattern along the podocyte cell body, but what they don't see is there's no IgG subtype restriction. There might be stronger IgG1 and IgG2 staining, but there's no significant restriction for any of the subtype. And same thing for kappa and lambda light chains. They show the equal, similar staining, the punctate dusting staining over the podocyte cell body. However, there is no kappa or light chain restriction. And PAS is showing these glomerulus here is pretty unremarkable. And then on EM, you could observe these diffuse podocyte food process effacement. So what we did is that we send our patient specimen to the same lab who identified the autoantibody to nephrin from Dr. Astrid Weiss, the lab at Brigham Women's Hospital. And the two images are shared from the lab. So on the left panel is the IgG, and on the right, the red immunofluorescence is nephrin staining. So what you can see is here again, you could appreciate those dusting, finding granular staining along the podocyte cell body here. And on the right is the nephrin staining for the same patient material from a different level. And the red staining is highlight the nephrin. And when you merge those two images together, you could see these kind of yellowish staining, which means the overlapping of those two staining IgG and nephrin, which kind of provides an indirect evidence that there is co-localization of the IgG antibody and nephrin, which is an important sleep diaphragm protein in the podocyte. And it's the staining and co-localization is mainly along the along the glomerular basement membrane here.
So Yuan, I would just add here that normal nephrin staining is going to be along the capillary walls, since it is a slit diaphragm protein and integral protein in the podocytes for their function and structure. But what we're seeing here is also we're seeing cell body staining in the urinary space, essentially over the podocyte cell bodies in that same kind of punctate pattern that the IgG was staining. So, and this has been seen by Dr. Wine's group as well, that this the autoantibody can bind to nephrin and kind of cause mislocalization potentially within the podocyte. But that is, rather than being on the basement membrane, it is now in the podocyte cell body. So that's kind of the staining pattern we're seeing here.
Yes, thank you for saying that. And now putting all these together, so the patient has membranous nephropathy as the initial presentation and was treated. It was in remission, and then the most recent biopsy, there was minimal change disease. He also has diabetic nephropathy. So putting all this together, can you think about any kind of syndrome or anything that could lead to this? I know the answer was kind of revealing in the previous slides. So this is a question for the audience.
So I think we can keep going, Yuan, since we have a second case too. But I think the point here really is that with the prior diagnosis of membranous, the current diagnosis, more recent diagnosis of minimal change. In a way, we can add this to the tally of autoimmune diseases that the patient had, and it kind of nicely emphasizes the presence of the autoantibodies and an autoimmune component to both membranous nephropathy and now more recently as described for minimal change disease. And given his early type 1 diabetes from age 4, poor glucose control with an A1C of 9.3, he's also developing some diabetic nephropathy with long-standing diabetic disease as well. And then I guess the final thing was about the tubulointerstitial nephritis. And so that has also been reported for IPEX patients. And the way I think about that is, again, a break in tolerance. You could almost think of this as kind of similar or analogous to the tubulointerstitial nephritis you might see in the context of immune checkpoint inhibitor therapy. So really, all the brakes on the immune system are broken here, and this poor patient is reacting in a lot of different ways against the kidney here.
Yes, exactly. So as we discussed earlier, the IPEX, the so-called IPEX syndrome, is a monogenic immunodeficiency disease caused by the FOXP3 mutation. And FOXP3 is a very important transcript factor for the T regulatory cell. And because of the mutation in this FOXP3, the maintenance of immune tolerance and also the prevention of excessive immune responses is gone with the absence of T regulatory cells. So the presentation most commonly is the clinical trial of watery diarrhea and endocrinopathy, and also dermatitis, eczematous dermatitis. The diagnosis is by the identification of hemizygous pathologic variant in FOXP3. So as we discussed, FOXP3 for the IPEX syndrome, there is a French multicenter retrospective study, and for this study, they studied 30 children from 26 families, and the age at onset is about 1.5 months, so pretty early. And then the initial presentation most commonly is diarrhea, followed by type 1 diabetes and the skin lesions. Nephropathy is not that frequent, it's about 3%. And during the course of disease, there are other symptoms that might develop, for example, diarrhea and skin lesions. So nephropathy is about 25% in those patients. So continue with that multicenter retrospective study. The immunosuppressive therapy led to improvement in 8 of these 26 children, and 3 boys displayed a stable disease course without any medication. And then the overall 10-year survival rate was about 43%. So our patient is actually doing pretty well. And then there are some new FOXP3 mutations identified, and the missense and frame shift mutations was associated with poor survival. For renal manifestations, clinically it could be proteinuria or microscopic hematuria and renal insufficiency. And membranous nephropathy is the most common pathologic type in children with IPEX. And then tubulointerstitial nephritis, as we see in our current case, there is a little bit nephritis and also minimal change disease as well. So does MPGN. So the question is, for those membranous nephropathy, could it be PLA2R positive? Yes, it was reported in this case report. So what they stain, so the light microscopy A and B, and the PS stain is showing you the representative glum here. This image is actually kind of a pseudo crescent formation here. And C, so image C is for the IgG, IHC staining, and figure 4 is IgG4. So they actually did the subtyping. It was positive for IgG4. And this is a silver staining showing the rare spikes of the glomerular basement membrane. And image F is the POA2R IHC staining, so which is positive along the granular along the peripheral capillary wall. And the EM is confirming the subepithelial electron dense deposits. So it could be POA2R positive. And in our patient, we actually did the FOXP3 deletion. I mean, we see if there is any FOXP3 deletion. What we found, so this is a gel for the PCR project. And if you focus on the left half, so those two bands, I believe, is from the patient. And this is positive control and negative control. So negative control is negative and positive control is showing the patient is basically have the same band as the positive control, and which is exon 1 deletion genotype. So this confirms that our patient has exon 1 FOXP exon 1 deletion, and this is the integrity test, which showing the band in all of the samples. We also did a flow cytometry study for our patient. What we can see is the upper half is healthy control in healthy control patient. So for Treg cells, they have the FOXP3 and 20. So they are CD25 and the FOXP3 positive. So in this red area is where the Treg cells, they are located on the flow cytometry chart. And then they could also, so FOXP3 positive and Helios positive, 25 and CD127 positive, like double positivity markers the T regulatory cells. And for our patient sample, if you look at the Treg area, it's totally blank. It's not present in this Treg area. Same thing for this and the CD25 and CD127 dual positivity. So this confirms that the Treg cells is not present, is totally deleted in our patient. So this is a follow-up.
Yeah, so so just briefly, so admitted to hospital, creatinine actually improved really with diuresis for those who believe in any sort of nephrosarca type diagnoses. The kidney biopsy was done a couple of days later, came back with minimal change disease. Patient was kind of reluctant to consider steroids, and we actually restarted the cyclosporin. We aimed for a target of 125 to 175. And by day 12, the serum albumin had actually improved to normal, although still had significant proteinuria, and the edema resolved. And by 6 weeks, the creatinine was down to 1.5 with a urine protein creatinine ratio of 0.7, albumin 3.5. And then 6 months following admission, creatinine is 1.3. His baseline before this was 1.1, so maybe slightly elevated. But his protein creatinine ratio is 0.3 with a serum albumin of 4.2 in complete remission. And so the ongoing discussion then is what is the best combination of immunosuppression for him? On the one hand, CNIs are quite attractive for this for the mechanism of this disease, and he does respond well to them in addition to his other medications. On the other hand, there was concern about CNI toxicity on his kidney biopsy. So this discussion kind of goes on for the long-term plan for him. Some discussion about mTOR inhibitors, which have been used in IPEX syndrome and other patients. So that's where we are at the moment.
Thanks, Ashley. I think one other point I just wanted to make, I don't think was clear in the discussion, is that it's a very rare disease, greater than 1 in 1.5 to 2 million people incidence. Then the definitive treatment, again, because the patients have a defect in their T cells, is a bone marrow transplant. Yeah. And this patient has not received a bone marrow transplant or has declined one. Is that correct, Ashley?
It is. It's certainly been discussed with him in the past. He's had some mental health issues as well, and that's been part of the discussion.
Yep.
Okay, any questions for this case?
Ashley, would you consider rituximab? I mean, he doesn't have FOXP3 regulatory T cells, but it does decrease the level of effector T cells and then can lead to long-term remission.
So we didn't consider that in the acute phase, and he has responded pretty well. So it's really more of a long-term immunosuppressive plan, but there really isn't a clear single guideline for how best to treat these patients.
There's a question from Dr. Young in the chat.
Okay. See.
Yeah, I answered it there as well. So, Yuan, maybe we should move to the next case just because we only have 20 minutes left.
Okay. Okay, that sounds good.
Thank you.
Sure, thank you. So for case number 2, we'll start with the clinical information. Is Dr. Aurora online?
Yep, I'm here.
Thank you.
So this one, the history is relatively brief. This is a 27-year-old female who was referred to me by her PCP for an evaluation of proteinuria after relocating to Seattle from Texas. And it's the records were relatively sparse that she came with, but it seemed like she was previously followed by a nephrologist while living in Texas for about 6 years. And the initial identification of proteinuria was in the context of getting a cholecystectomy for symptomatic gallstones. So incidental finding where she was found to have a UACR of 100 milligrams per gram. She then underwent a 24-hour urine collection that showed 400 milligrams of proteinuria, and at the time was using about 8 to 10 tablets of ibuprofen a week. And per the notes, the proteinuria was attributed to NSAID use before she established with a nephrologist. You can see our initial review of systems here, pretty benign. There was this question of palpitations, but other than that, nothing on review of systems. So past medical history, so other than the gallstones that she had a history of depression. She reported no history of significant childhood illnesses, no vision or hearing problems, no hypertension, no diabetes. You see medications here. She was on sertraline for the depression, otherwise took over-the-counter vitamin C, D, and B12. At this point, denied any further NSAID use and no over-the-counter medications, herbals, or other supplements. And as stated, she relocated to Seattle to work for Amazon, denied any tobacco or recreational drugs. She's a daily exerciser and denied any relevant family history. So from records from Texas, the labs that I had available to me, it looks like a urinalysis at some point had 2+ blood, 4+ protein. It looked like she was undergoing annual 24-hour urine collections that were typically between 500 and 600 milligrams of protein. The serologic workup I could find is in red here. So a negative ANA, negative paraprotein workup, negative hepatitis B and C, and a negative RPR. There was a report of a kidney biopsy in 2018. I didn't have images, but the report stated 38 glomeruli, negative IF, LM, and EM, and the interpretation in the summary was that this was completely normal kidney tissue. So when I saw her initially in clinic, this is her physical exam. You see, normal vitals. Physical exam was totally normal. A kidney ultrasound showed normal size and morphology of her kidneys bilaterally. And on the next slide, we're going to have her initial labs, which pretty normal chemistries there. A repeat urinalysis had 1+ protein, 2+ blood, but no red blood cells. A spot UPCR was 0.6 grams per gram, and a UACR was 268 milligrams per gram. Additional serologic workup showed a negative ANA, antiphospholipid antibodies, normal CK, normal complements, and a negative ANCA. We tested for orthostatic proteinuria, which was negative, and then repeated a UACR after avoiding exercise for 3 days, and you can see that it was 443 milligrams per gram. So that's essentially the history.
Okay. Now, thank you. Now we have the kidney biopsy. We have about, so this is a very good sample. We have about 24 to 25 gram per level section, and all of them are patent. And the renal parenchyma is pretty well preserved. There's no significant tuber atrophy, interstitial fibrosis, or any kind of interstitial inflammation. And this is a kind of closer look of the renal parenchyma. It looks pretty well preserved. We don't really see significant chronic parenchymal injury. And the artery here looks pretty unremarkable. Same thing for the gland at this low power. And this is a high power view of the gland. Move this away. So what we can see is that there is no extra capillary proliferation, and the green arrow is pointing to the subtle changes we see in the gland. So this is a podocyte, and probably a podocyte, and you can see those foamy cytoplasm for this cell, and then occasionally you could see this rare intracapillary hyaline material. It's kind of affecting one capillary lumen, capillary tubes, and we don't know like what is causing this. So interesting, what we see is that so IF is completely negative. And interesting, what we see on by electron microscopy is this finding. So the podocytes, they so this is a podocytes, and this is the capillary loop here. So the podocytes, they contain these numerous lysosomes, and the glomerular-based membrane, they are kind of on the thinner side. So we did the measurement at higher magnification, and it turned out to be average approximate thickness was 256. So it's still not meeting our criteria for thin basement membrane disease for a female patient. And then this is a closer look for those lamella osmophilic inclusions, the so-called myeloid bodies. So the final diagnosis for this biopsy is there is ultrastructural evidence of lysosomal storage disorder, and the focal obliteration of real glomerular capillary loops by hyaline is possibly secondary to number 1. We feel like it's not sufficient to call it FSGS based on the rare obliteration of capillary loops. But FSGS has been reported in the setting of Fabry disease, which is one of the lysosomal storage disorder. And then this is a post-biopsy plan.
So, sorry. So, this was a bit of a surprise. With the diagnosis, I was actually curious how many people would have biopsied her in the first place. But when we got this diagnosis, the caveat being she had already moved back to Texas because her mother was ill. She had just flown back for the biopsy, actually. And so we established her with a nephrologist down in Texas. And the plan had been to, do a cardiac workup, ophthalmology workup, pulmonary workup, and actually get genetic testing while arranging for enzyme replacement therapy. So all of that was the TTE, ophthalmology exam, PFTs were normal. And in that amount of time, the genetic testing came back. If you go to the next slide, and it was actually negative for Fabry's disease, but showed a tubulin mutation. And I don't know if you're going to talk about that at this point.
Yes. So the alpha-galactosidase, the GLA, is the enzyme responsible for degrading GL3. And when it's deficient, it's either due to genetic Fabry disease or acquired, for example, hydroxychloroquine is well known to lead to the accumulation of GL3 in the lysosomes. So basically by EM, they can have pretty similar morphologic findings. And by histology, the cells can have foamy cytoplasm. Also, you can see by EM, there could be those myeloid bodies or zebra bodies. So for Fabry disease is an X-linked lysosomal storage disease, primarily affecting the male patient. And there are 3 types based on the sex and development of symptoms, whether it's early onset or if it's later onset. So for female patient, it's usually asymptomatic, but it can be variable. It can be asymptomatic or renal failure. And that's why we did one of the reasons we did genetics testing. It's usually recommended for heterozygous females or atypical male cases. And then this is a genetic testing result. Surprisingly, what we found is the cubullin, homozygous cubullin mutation instead of the GLA mutation. So there was no GLA mutation identified. This is kind of a surprising finding for us. The cubullin mutation, so what is the cubullin? It's a large endocytic receptor. It can be found in complex with megalin and MLS. The function is basically in the bowel system and in the kidney. So in the intestinal, it's kind of involved in the intestinal absorption of the intrinsic factor in the B12 complex, the vitamin B12 complex. And also in the kidney, it was reported initially in the proximal tubule, reabsorption of the filtered proteins. For example, albumin is one of them, is important. And also recently it was reported to be present in human and animal podocytes, in addition to the expression in proximal tubule cells. So this is on the to show you the megalin, cubullin, amylase, endocytic receptors in the proximal tubule. So we have the 3 molecules here: the receptor, the amylase, cubullin, and megalin. And what it does is that there are 3 main ways for those transportation. One is some of the ligands, they will only bind to megalin. However, some can bind to the complex of megalin and cubullin, but usually cubullin will need the help from megalin to bind to the ligand. There are some ligands that bind only to cubullin. So this is on the right side is kind of a table to show you the ligand table for the megalin and cubullin. So for albumin, they usually need both of them, megalin and cubullin. And for GLA, as pointed out here, what has been demonstrated and reported is that megalin is a major molecule to help GLA transportation in the proximal tubule. And then if we look at the molecular substructure of cubullin, what we can see is that it's composed of the N-terminal and C-terminal. So there are 8 EGFR-like domain, and then 27, the CUB domain. And then there is a vitamin B12 intrinsic factor binding region, and also some red dots is to showing the calcium binding site. So the C-terminal half of the cubullin is critical for renal albumin reabsorption. And what that means is that the albuminuria due to reduced cubullin function could be an unexpected common benign condition. And the red arrow is pointing to what identified in our patient's mutation. So it belongs to this C-terminal half of the cubullin molecule. And it can at least partially explain the albuminuria. And then the question here is that we do see those EM by EM, we do see those myeloid bodies in the podocytes. So what is causing this? I mean, we talk about the medications, for example, the hydroxychloroquine, and that basically is ruled out because the patient's not taking any drug, known to interfere with the lysosomal acidification. Also, we don't see the mutation for the GLA mutation. We don't see that. And the question we have here is that, is there a potential association between the QBL mutation and lysosome storage disease? That question is kind of interesting. But so what we further explore is that in the podocytes, are there expression of the alpha-galactosyl-A, but it's actually not identified, interestingly. So what in animal models, what they found is that the recombinant, if we inject this recombinant molecule into mice, it will be localized to endosomes and lysosomes in the proximal tubules and the interstitial cells and glomerular cell, the podocyte, but not the endothelial cells. And for the cellular receptor for alpha-galactosyl is megalin is one of the important cellular receptors for those. And importantly, the podocytes in vitro, they can take up this in the molecule in a megalin dependent manner. So what we are trying to convey here is that megalin is a very important molecule for the uptake of alpha-galactosyl-A. So where is expressed from this tissue expression study, what we can tell from this study is that it's primarily expressed in myeloid cells, including macrophages. And podocytes is not among these. And again, this is from the KPMP study from the single cell RNA sequencing from the KPMP study. What they prove is that it's mainly detected in M2 macrophages and monocyte-derived cells. However, there is no significant expression in all other cell types. So the question remaining here is that how does the GLA get into the podocytes? So maybe it's expressed at low levels and we just cannot detect its expression in the podocytes, or it's expressed by other cells and then it's taken up by the podocytes while the receptor mediated by the endocytosis, and whether QBL will influence the GLA uptake in podocytes is still not known. It's still a mystery. So any questions for the second case? I think we have 4 minutes for questions.
Ewan, we know that megalin is not expressed in the podocyte. Is QBL expressed by the podocyte?
Yes, it is. It's kind of a more recent study. I don't have the reference here, but I can send you the reference later. It was recently identified that the QBL was expressed in both human and animal podocytes. Yes.
And Ashley, megalin also has been shown that at the low level expresses in megalin in human podocytes as well. It can be detected. For years, people were thinking that it is not expressed at all, but now we know that it is expressed. I mean, Eric Christensen showed that, and also, I mean, in very rare forms of membranous nephropathy, you can find antibodies against megalin.
I'm hearing sort of conflicting data on that. I heard that KPMP, there wasn't megalin expression detected.
Yeah, and for the alpha-gal expression, I have to say that so the intracellular half-life of alpha-gal is very long. It's 2 to 3 weeks. So when there are multiple evidences that point to presence of alpha-gal and the podocytes. I mean, one thing that we have to consider that there is only 3% of alpha gal in the cell is contributed by the mannose-6-phosphate receptor, megalin, and sortilin combined. So most of the intracellular alpha gal is internal. And a good evidence for that is when we look at the females, we see mosaicism, even though that the females may have normal plasma levels of alpha gal. Basically, as you can see, that the podocytes that, because of the mosaicism, they don't have the normal GLA expressed. They're filled with GL3. And on the other hand, if we look at the biopsies from transplants of normal kidneys into Fabry patients not receiving enzyme replacement therapy, podocytes do not reaccumulate GL3 at all. We occasionally see endothelial cells that reaccumulate, and those are believed to be coming from the host. So the intracellular alpha gal should be present. When we stain the normals, of course, we see very granular, fine granular cytoplasmic staining in the podocytes, but in the normal people, we can't prove that if it is coming from the plasma or it is intracellular. But as I said, there are multiple evidences that point to that intracellular alpha gal is indeed present in the podocytes, and most likely it is not that much dependent on the plasma levels. So it would be interesting. One question that I have in this particular case is the genetic testing that was done, was that exome sequencing? Because if that is the case, it has the caveat. We know that in females, because, again, of mosaicism and because the disease is X-linked, plasma levels of alpha-gal could be misleading, and we need to do genetic testing. And if exome sequencing was done, large deletions and intronic mutations may have been missed. But there are cases that we do not know. If you do whole genome sequencing, if you do Sanger sequencing, whatever you do, we can't find any kind of mutations in the GLA, and still they show these features. Although, the presence of these lamellar bodies are not restricted to Fabry, and like Niemann-Pick C, you can see those, and also in drug-related, which was not the case for this patient.
Yeah, I don't know if exome sequencing was done. This is what was sent to me from her nephrologist in Texas, so I'd have to look at the whole report.
And then, sorry, I missed the initial part. What was the creatinine?
0.7.
Yeah, I wonder, like, if the patient, progresses and gets a transplant, is there a risk of anti-breast border disease post-transplantation?
Yeah, it's interesting. Most of the clinical things I saw related to this mutation suggested that the proteinuria is benign and usually not associated with any progression, and generally no treatments indicated. But there's only case reports out there.
Yeah, I think the one thing I'd add is that I don't think we have any clue why this patient has those myeloid bodies in the podocytes, and probably the only benefit from us finding those, or true benefit, is that that triggered the genetic testing, which actually led to an understanding of why this patient has albuminuria, and then also led us to understand that this has actually been studied, and that data that Yuan presented indicated that there's a fair number of patients that have this C-terminal mutation in cubulin, and they can't uptake any of the albumin that's filtered, and they have albuminuria, but they don't really have any other consequences other than the fact that they'll often get a renal biopsy because of the albuminuria. But the kidney function doesn't seem to be impaired, and there's no other really phenotype associated with it. So the myeloid bodies led to the discovery of this cubulin mutation, and also I think an appreciation for the fact that this is a potential cause of albuminuria in your patients, that if you figure it out genetically, you can reassure them that they're probably going to have albuminuria for the rest of their life, but their kidneys are going to work too.
Yeah. Nayan, any cardiac symptoms, problems? Because one thing that in females with Fabry disease is not uncommon is cardiomyopathy, left ventricular hypertrophy. Anything that?
Yeah, so clinically, there was this question of maybe palpitations in general. So I asked one of our cardiologists, would they get just a transthoracic echo or a cardiac MRI when we thought this was Fabry's disease, and they recommended just a TTE, and that was negative for normal.
Thanks.
Okay. Yeah, I think that's all I have. If there is no further question, maybe I should check the chat.
There was a lot of good discussion in the chat, but I think that mostly closed the loop. So we may end there just for time. We'll close out. But thanks to all of our presenters, the discussants,